Yo, what's up, man? Want to hop on here with me? What did I just have? Trader Joe's ranch garbanzo beans. Sounds weird. It's actually really good. You and I are officially the only ones on here right now. That's crazy. You can enjoy the course, by the way, man. Great MR. Oh, you're literally working right now? What are you doing on here right now, then? You got a break and you're dictating. I would go, like, take a piss or something. What's going on, guys? What up, what up, what up? Multitasking. Don't miss a stroke while staring at me for no reason. $168 studies? What is that, a 10-hour or 12-hour shift? Is mainly plain films, cross-sectionals? For anybody joining right now, I'm talking to the radiology guy. He's at work right now. Just cranking away studies. 168 studies, that is a lot. He 4 to 11:30. Man. That's a busy time, by the way, for anybody else not familiar with the 40%. Man, that's a lot. Like 4 o'clock to, like, I don't know, 11 midnight-ish. That's a busy time. Everybody comes into the ED after work. You know, people are driving home, they get into car accidents. It's a crazy time. And then usually around like 2, 3 a.m., things start slowing down and you just get the occasional like head CT for, altered mental status. The guy who's drunk walking in around like 3, 4 o'clock. But yeah, like, man, 8 o'clock, 9 o'clock, 9 p.m., it's tough. Should I be home or should I get to the toe pain checked out? Yeah, seriously. Everybody puts it off and they're like, oh, I'm going to go to work, all that stuff. And then, like, 7 o'clock, 8 o'clock, like, oh, well, my stomach's been hurting all day. Let's go to the ED and get an abdominal CT. And then I just tell you that the guy has a lot of stool and somebody needs to disimpact it. What up, you guys? How's everybody else doing? Who's coming on? Let's see. Let's say what's up to everybody. What is it? Will Pez? Is that how you pronounce it? Nalag 21. Dr. Dev, what's up? KB11. Oi. Pietro, what's up? What up, what up, what up? Eat your bran flakes. Why there's so many people constipated? I know. So many people. Well, okay. Yeah, that's funny you mentioned that. Literally, like, we get so many KUBs for constipation. All I can tell you is that, yeah, there's a lot of poop in there. Otherwise, hey, it's up to them to kind of figure it out. And men, art, what's going on? Dr. Oniros, what's up? Sila? First year rad tech student. Nice. Nice. We're going to depend on you for some really good chest x-rays soon. Keep them coming. Donna, there you go. Send any good chest x-rays my way. What up, you guys? Sarah Roberts, what's up? Your pretty Patty, what's up? How's your guys' day? Anything good? How to read a chest radiograph. Oh, you know how to read it? Go to my bio, click on the YouTube link, go to the YouTube page, and go to the thing that says chest x-ray. You can't miss this. And open up a bag of popcorn and enjoy, my friend, for 1 whole hour of chest x-ray goodness. I'm a medical student, 4th year. Does that mean you're almost done? Congrats. What are you going into? Say radiology. Otherwise, we're not friends. It's Ray. Thanks, man. Appreciate it. It's a really good video. I was trying to do, so I went over CT abdomen with some med students today at noon lecture. And I was trying to I was trying to live stream it for you guys, and I don't know, my internet just wasn't working, but we went over the basics of CT abdomen, how to read it, all that good stuff. But I'll do another like hour and a half session on how to read CT abdomen and give you guys some cases soon. I start night call as a second-year resident in a few weeks. Any strong resources to bone up? Oh man, night call. That's gonna be tough, but that's the most learning, seriously. What's a good resources or a good resource? I never really had any books like nearby per se, but I had a lot of online resources ready to go. Xrayhead.com, headneckbrainspine.com or .org, something like that. Radiopedia, StatDX, all that stuff. I always had those like already pulled up when I was on call. Fourth year going into rads. Yes, I like your style. Pulmonology. Okay. I like it. That's good. Mr. Jarto 7. I like it. X2 effect. So what's up with you guys before we get over to the case of the day? Anything else good? Anything new? How's life? You guys enjoy the, what was it yesterday? April Fool's Day case yesterday? It was kind of a fun little case. It was on Radiopedia. It was a couple of years old, so I didn't want to do the one that was like their current April Fool's joke, which is actually a really good joke. It got a lot of people. All right, should we get into the case for today? All right, let's see. Let's try to put this picture up. And here it is. All right. So we got the pictures up. This is what we're looking at, right? And then I said, what's the anatomy? Let's just straight up go over the anatomy, right? First of all, CT or an MRI, we're breaking this down. Okay, so how do you know the difference? Can you really see bones? Not on this blown up version, but yes, on the version that I posted on my stories, you can see the ribs, right? I've always told you, whatever bones are super bright, it's a CT scan. If it's not bright, it's an MRI. So done deal. We already know that it's, number one, a CT scan. Number two, you have to tell me, is this contrast opacified or is this not contrast opacified? Well, it's kind of nice. We're looking at the heart. We're looking at the huge vascular structures. Everything's lit up. Therefore, this is a contrast opacified CT examination. Next thing you have to tell me, is this an axial cut? Is this a sagittal cut? Or is this a coronal cut? This is a coronal cut. So this is basically how I would answer this question in case conference. I have a coronal cut through the chest of a contrast opacified CT exam. All right. I know you guys, this may be repetitive and redundant for people who are really good at this portion of it, but everybody's got to know the basics. You literally can't run before you even not even crawl. You just have to know the basics and you have to say it every single time. So we figured out what it is, what type of study. We figured out where on the body this is. It's in the chest. For anybody who's unfamiliar with what's going on here, it's the heart. All right. And specifically, can anybody tell me, I don't know, so this is like the heart, right? I know I can't really point to it right now, but this is the heart. What's this ventricle, left or right? And then compared to this ventricle, is this left or right? Actually, I shouldn't say ventricle, but this is the ventricle. Which one's this one, the thick one? That's the LV. How do I know this is the left ventricle? Should I give somebody time to start typing? So I know this is the left ventricle, this one over here, because it's got, number one, it's thick. I completely agree. And number two, what is the big vessel that's coming out of it? What vessel comes out of, perfect, the ascending aorta. So I know it's the LV because it's connected to the ascending aorta. Perfect. Somebody just said, you can see the aortic valve. Do you see those little leaflets? And it looks like a little tulip on the bottom. It's got like a little W thing right here, right? So that's the aortic valve. So this is the LV, and I know it's the LV because one, it's thick. It's concentrically thick, right? Because you want a thick myocardium because it's the actual pumping ventricle for blood to go out into the systemic system. That's kind of redundant. Anyway, and then you can see the valves too, that little W right there, okay? Right where it starts going into the ascending aorta. And then everybody remember the branches of the aortic arch. I've said this many, many times before. If you want to go over it, we can do it. What is the mnemonic that I like using? ABCs. Big A, big B, big C, tiny little s. So the ABCs, okay? If you look at the A, it's going to be the aortic arch. B is the brachiocephalic. C, common carotid. And then S is going to be left subclavian. All right, so ABCs. That's the ABCs of the arch or the ascending aorta. Remember that, okay? That's very important. We're not dealing with the aorta, right? The questions that I asked were all about the venous system, okay? How do you know it's the venous system? Well, one, we've already completely excluded the aorta because we know it's coming off the LV. It's ascending. We already dealt with all that. Number two, look at the vasculature. If you look up top, you're going to see the brachiocephalic and then the common carotid going up, up, up. And then just lateral to that, you're going to see the big arrow that I pointed to on my second story. And I said, what are these two vessels? I had one arrow here and then one arrow here. And those are the internal jugular veins. I got a couple of answers about the external jugular vein. It's not external. That's the IJ. This is the vessel that you go for when you're going to place a central line, okay? You want to go for the internal jugular vein. Rule of thumb, veins are bigger than arteries, okay? So if anybody just happened to slap open a CT scan and they said, what vessel is this? Even if you don't know any anatomy at all, just say, hey, you know what? Is this bigger than the vessel next to it? And yeah, then I'll be like, okay, well, Amrit once told me that veins are, for the most part, bigger than arteries, so I'm just going to guess it's a vein. So I pointed to some vessel that was larger than the vessel just medial to it. So the vessel just medial to it was the common carotid artery, and then the vessel lateral to it, the one that I was actually pointing to, was the internal jugular vein. Remember, that's what you want to get access into when you're placing your central line, okay? So this is my right side. I know maybe a little flipped for you guys. This is a right IJ. So and you're going to place a central line in somebody, you get access here, and then it goes straight down into the heart. And then what's the vessel that connects the IJ into the heart is going to be the SVC, all right? So the SVC is the superior vena cava. Obviously, you have an inferior vena cava as well, and that's what dumps into the heart, all right? So that's what the first question I had pointed to. Now the main question that I wanted to, yeah, your heart doc, he got all excited because I'm looking at a heart right now, right? So the other question is where do you want your central line to be? Where is the tip of your central line? Where do you want it to ultimately lie? You have to tell me off of CT. First of all, anatomically, you just tell me. You want to be at the cavoatrial junction, the junction of the SVC and the right atrium, or the SVC-RA junction. You want your central line to stop right there. Why do you want it to stop right there? All right. First of all, what happens if it stops way up here? All right. So the heart's down here, the right atrium's down here. And then what if my central line stopped way up here? Is that bad or good? What could be the problem? If I placed a port like that on somebody and I left it way too high, well, guess what? Hey, the port actually has a capability of that catheter flipping up and kind of retracting a little bit, and it can get itself into some weird other areas, maybe flip up into the IJ, flip back for some weird reason into the subclavian, maybe go into the azygos vein. It can flip into weird areas. So that's not good. What if I left it way too far down? Remember, the atrium's over here. What if I left the catheter way down into the atrium? What's the bad part there? Number one, sure, you can tell me some sort of arrhythmia. Absolutely, that could happen, sure. But the other main thing that you want to worry about is that catheter, first of all, is not going to be tickling the side of the atrium, which is not good for a couple reasons. The first reason, if you keep tickling the side of the atrium, again, you can talk about arrhythmias, all that stuff, but you can actually form a clot or a thrombus around that catheter just by irritation. And a lot of the times what we find is called a fibrin sheath. So the fibrin sheath can form around that area, which is not good. That's going to suck. Anytime, I guarantee you that you will run into this problem. Somebody has a catheter and the nurse is going to say, well, I can flush the catheter, meaning I can push saline through it, but I can't aspirate anything back. That's 100, I shouldn't say 100%, but that's very likely because it's a fibrin sheath. And what is a fibrin sheath? Well, here's the tip of the catheter, and then there's a sheath that's going to grow around this. Literally, it's called fibrin. It's a sheath of fibrin that's going to grow around the tip of the catheter, and it becomes like a little one-way door. So when you flush the catheter with saline, it's going to open up, and then the saline is going to flush through. And then when you aspirate and you try to suck blood back, it's going to go in, it's going to shut down the tip of the catheter. So that's what's going to happen. That's going to be the issue. You're going to get a fibrin sheath, and then it's going to be this whole issue, and then we're going to have to figure it out and kind of replace the port. And again, we already mentioned the arrhythmias, and then the other thing. Okay, and then so where do you want it to lie? You want to be at the cavoatrial junction. Why is that? Because if you look at the cavoatrial junction, there's no valve right there, which is beautiful. There's no valve. It's not deep into the atrium. You're not going to cause some arrhythmias. You're not going to have the fibrin sheath. You're not going to deal with any of that stuff. It's not too high. It's not going to flip around doing whatever, go back up to the IJ. At the cavoatrial junction, there's no valve right there, and it's just dangling freely in that vein. It's not going to hit the side of the wall. Nothing. It's going to be perfect. That's where you want it to be. The next thing is, how do you know where the cavoatrial junction is on a chest x-ray? Because you're going to get chest x-rays all the time after you're on the floor, and you're going to place the IJ line, and you're going to say, oh my God, I hope there's no pneumo. You know my spiel about that. If you can see the tip of your needle every single time you're placing a central line, there's no way you should ever be even concerned about a pneumothorax. That's just my spiel. So you better get real good at placing lines with ultrasound, using ultrasound guidance, not assistance, where you're slapping the ultrasound on the neck and all of a sudden all you're doing is looking for this tissue to displace up and down. You don't ever see the tip of the needle. Don't practice that. Practice finding the tip of your needle every single time into the IJ. You always know you're in a vein. You never have to question it. Anyway, I went on a little tangent there. What was I talking about? I don't even know. I was talking about, what was I talking about? Man, this is what happens when I go on tangents. I talked about the cavoatrial junction. I talked about, chest x-ray. You got the chest x-ray now. And how do you know where the cavoatrial junction? I've said this before too, but I like reiterating it because we get this question a lot in radiology. You look at the carina, right? So here's the trachea coming down, trachea's coming down, and then the carina does one of these, and then the right main stem is steeper. Again, I don't know if this is right side for you guys. It's all flipped. And then the left side is more kind of horizontal. That's why everybody aspirates down here into this right main stem. And you want to be 2 vertebral bodies below the carina. That's your general rule of thumb. Don't count ribs. Don't say next to the heart. Don't say next to the PA. All that stuff, forget it. Look at the carina and find 2 vertebral bodies below that. That's your cavoatrial junction, all right? The other thing, if you think you have placed a line way too deep into the heart, so if you look at the atrium right here, the right atrium on the picture, it's like, you can see where it is right there, right? If you look at a chest x-ray and somebody doesn't have a deep inspiration, meaning they're taking a big deep breath in, that's going to open up the thorax, the lungs are going to get huge. If they don't have that and they're in the ICU, and they're not taking a deep inspiration, the lungs are kind of expiratory, it's all just kind of crunched down, well, it's going to look like the catheter is sitting super low, and you're going to be like, oh shoot, I think it's in the atrium. But guess what? The atrium is actually really deep in there. So go off of the carina and 2 vertebral bodies below, because I promise you, just by looking at the chest x-ray and eyeballing it, thinking your catheter is in the SVCRA or the RA, it's a big difference when the patient takes a big deep breath in, or the patient has a terrible inspiration and their lungs are all kind of squished down. Guess what? That's what I do to make my images look pretty. When I'm done placing a port or a central line, I tell the patient, if I don't like it and if it looks just too deep, and I think the clinician's going to look at it and they're going to kind of try to critique me, be like, oh man, this interventional radiologist doesn't know what he's doing. Look at how deep he left this line. I know the trick, so I tell the patient, I say, Mrs. So-and-so, Mr. So-and-so, take a big deep breath in and hold it. And they take a big deep breath in, they hold it, and then I take the image. And then it looks beautiful. And then you guys are like, oh man, how do you do that? That's pretty cool. All right, that's my little spiel right there. What questions did I miss? You guys ask some more questions while I scroll up and then try to get to all these. What's up, Rad Girl Creations? Who else? Dr. Fabulous, what's up? Pressure if too distal can cause PACs or PVCs. Yep, nailed that. Like my teaching style. Thank you. I see this with swans all the time. Yeah, man, we see fibrin sheaths so many times. We get consulted all the time for fibrin sheaths. Wish rad tech school would have rads come in and teach stuff like this. Yeah. Give me a call anytime. I'll come teach. Let me know. Can you just please save this live? Yeah, definitely. It'll be on live for the next 24 hours. How much variability do you allow before adjusting? So when I get done placing a line, when I get done placing a port, I need to make that port tip perfect because I know this patient has a potential of going out there for years with this port in, and they're going to need chemo all the time. They're going to need blood transfusions all the time. And I don't want it to be a bad placement because that can really affect patient care and it can suck. Then they have to come in and then they have to get it adjusted, all that stuff. So I really want to make sure my port catheter is placed perfectly at the cavoatrial junction. I will test it out. I just had one the other day. I measured incorrectly at first and the catheter was too long and it did some weird little curve at the end and it kept like hugging the side of the right atrium. So every time I tried to aspirate, I hadn't closed up the pocket yet. I hadn't sutured, nothing like that. And you always test. I triple check. So the catheter was like kind of going to the side and it was like hugging the atrium. And every time I tried to aspirate, the atrium wall would get stuck in the catheter. So I wouldn't get any blood flow return. But I could flush perfectly, so they could get their chemo no matter what. But I knew it. If I sent this patient out and they tried to, nurse tried to access this back when they're trying to get chemo, every single time they aspirate first and then they flush. That's just what they do. And they're going to immediately say, yo, this does not aspirate. This port is malfunctioning, basically. So I knew that was going to happen, so I said, forget it. I'm not going to do that. So I took another couple minutes, cut the port appropriately. Don't worry about the steps. It's actually kind of complicated on how to adjust a port once it's completely in. But I adjusted it and then everything was completely perfect. So I really want to make it perfect for the patient, especially if these are long-term catheters that they're going to be using for years and years and years. Why would you want them to suffer and, maybe a year down the line have to re-access the port and then open it up, open up the stitch, open up the suture at that point, and then, do whatever you need to from there. How frequently should the catheter be replaced? Good question. So I think we've talked about this before, but I'm more than happy to go over it again. The sites of access that you want, if we're talking about central lines right now, well, I can take this image off, right? You guys don't need this anymore. All right, the sites of access for central venous access. Number one, again, this is my right side, maybe flip for you guys, but number one is right IJ. That's number one. You want to find a right IJ that's open and you want to go for it. Beautiful. Number two is left IJ. Go to the other side. It's a little bit longer of a course because you have to go down to the brachiocephalic and it can be a little bit more challenging at times. All right. Some people, I don't place subclavian lines. Surgeons like placing subclavian lines under the clavicle. Remember, under the clavicle. Some pulm crit guys like to place subclavian lines. I don't do it personally. I go right IJ first, left IJ second. Then if I can't use the arms to, for like a PICC line, anything like that, then I will go to the common femoral veins in the groin, okay? So the problem is the groin is obviously a dirty area. There's pee, there's poop, all that stuff down there, right? So you do not want to leave a groin line in for longer than 3 days, all right? So if you have a central line in the groin, whether it's a dialysis catheter, whether it's a central line, whatever it is, you do not want it to be in there longer than 3 days. It can be in for a little bit longer if you absolutely need to, but general rule of thumb, you don't want to do that because it's a dirty line. We can, though, tunnel the line into the soft tissue of the thigh and then have the line go into the femoral vein there. So the line exposed to the air is not actually the area where the vein is. Just like we would do a tunnel line from here, we could do the same thing down below, and that can last a while, all right? So that's 3 days. Up here, if it's a direct stick right into the IJ, into one of these IJs, those can last actually a while, like a week. If you can push it for a little bit longer, if you absolutely have to, that's fine. Tunneled central lines, when we poke into here and then tunnel it underneath the skin and then we get access into the IJ, you actually don't see anything on the IJ afterwards. That there's just a Band-Aid there, nothing. The catheter sticks out down here. Those tunneled lines, I've had patients going months and months and months. It's not common, but they can go months and months and months with that, all right? Remember, please, please, please remember this fact. If anything, if you forgot every single thing else that I'm talking about, remember this one fact. When I take out a tunneled central line, okay, I took it out from here. Remember, it's coming out of the skin here. So if I took it out, I sent the patient back up to the floor, and the guy's bleeding out here continuously. Do not hold pressure here. There's no vein here. Why are you holding pressure here? The vein is up here. I don't care if he's bleeding out of the hole here. You hold pressure at the IJ for 5 minutes, 10 minutes, however long it takes. Keep holding pressure here. I promise you this will stop because there's a tract underneath the skin that's connected to this vein. So it's actually bleeding under here and it's oozing through this tract and then coming out here. So do not hold pressure here. It will not do anything. He'll continuously bleed here and he'll develop this huge hematoma. And you think you're applying all this pressure here for 30 minutes and it's not stopping. Remember that, please. So tunnel lines, again, they can last months and months and months. The other thing is a port. If it's all completely underneath the skin, a port can last years. I've had patients come in. I've removed ports 10 years old. They can last years and years and years. What else? What do you do if you suspect line pinch off or why don't you do me a favor and go to one of my recent posts, and I have a case of pinch off syndrome, and go check out how we took it out. So pinch off syndrome, if somebody's not familiar with, it's usually with a subclavian line, when the line goes under the clavicle, and there's a common area right here around the clavicle, like the clavicular head, where it just keeps having all this friction against the central line, and it like breaks. It can either fracture like a little bit, there can be like a little tiny tear in the catheter, or it literally can just fracture off, and that distal catheter can go and embolize into the heart. That's what my case was. So go to my post and check it out. And if there's pinch off syndrome, if there's a concern for that, we have them come into our IR suite. We access the port and we inject a little bit of contrast under fluoro, and we usually see that contrast pool in this area right here, and we say, oh, it's pinch off syndrome. Then we have to take it out and then put it in a new port. Whew, that's a lot of talking. Any other questions did I miss? I don't think so. We good? Did that help you guys? You guys learn something new? Cool. I think we should call this and pick it up tomorrow, shall we? I'm going to wait for another couple. I got a thumbs up. Boom. Thumbs up. 2 thumbs up. Meaning deuces for you guys. I appreciate y'all. We'll pick it up again tomorrow. Oh my God, Rad Girl Creations with a question in the very end. Would you get pinch off syndrome in people with TOS? What is TOS? Is that something I should know? Oh, you're talking about thoracic outlet syndrome. Oh, would you get pinch off syndrome? Oh, that's a question. That's a question. Do you get pinch off syndrome and thoracic outlet syndrome? I got to look into that. I don't think that's ever really talked about, because that'd be so rare. So if anybody's unfamiliar, well, you're going to make me go down on this tangent now, aren't you? That's what you're making me do, Rad Girl Creations. You're making me go on this tangent of thoracic outlet syndrome, all right? TOS, as she abbreviated it. I'm not used to calling it TOS, but I like it. Thoracic outlet syndrome has 3 different things, 3 different types of thoracic outlet syndrome. Oh, hey, by the way, guess what? I had a post on it a long time ago, too. Man, I got posts on everything. So thoracic outlet syndrome, you can have a venous thoracic outlet syndrome, which is called Paget-Schroeder. You can have an arterial, and you can have a nerve, So thoracic outlet syndrome, let's talk about venous. Let's talk about Paget-Schroeder. Please do not get confused with SVC syndrome and thoracic outlet syndrome. Those are not the same thing at all. They are commonly confused for each other. Please, please, please remember what I'm saying right now. Do not confuse those two, okay? So thoracic outlet syndrome. Paget-Schroeder specifically is the venous form of thoracic outlet syndrome. And what that is there is basically 2 main things they love testing about on step 1, radiology boards, whatever. A hypertrophied scalene muscle or a cervical rib. One of those 2 things is going to go and it's going to kind of put some pressure on the vein right here, in the subclavian vein. And the patient's going to be totally cool when their arm's down, but then when they lift their arm up and they do like, shoulder presses or whatever, they're tossing their like, baby up in the air playing with them or something, they're going to complain that their arm's going to go numb and they're going to feel some weirdness, some tiredness, that kind of stuff. So what it happens is it actually pinches off that part of the vein, and then they can develop clots in there, okay? So that's Paget-Schroeder. That's something we're about to go down into the IR aspect of it as well, because this is what I do. I'm going on another tangent, a tangent of a tangent, okay? So Paget-Schroeder, we just talked about it. What do we do as far as an interventional radiologist? Well, I'm going to tell you what I'm not going to do. I'm not going to put a stent in that thing. Why am I not going to put a stent in that thing? Because if I do, and then the supernumerary rib or that cervical rib is still there, that hypertrophied scalene muscle is still there. Therefore, it will still put compression on that area where that stent is. And now the stent is going to collapse, and that stent is going to collapse down, which means I cannot go up and open that stent anymore, meaning I have just destroyed that vein, and that sucks for that patient. So what I can do though is put a balloon there through that vein, and I can plasty it open, and then I can send the patient to surgery and tell the surgeon, hey, do you mind releasing this thoracic outlet syndrome by either cutting that scalene muscle or taking out that cervical rib, and that usually takes care of it. All right. The other thing that I want to talk about with this is what do I want to talk about with this? I talked about the surgery, talked about blah, blah, blah. Oh, yeah. If you're concerned that your patient has thoracic outlet syndrome, what can you do? He has all the clinical diagnosis scenario. Oh, hey, I lift my arm up because all I do is ask questions in class. So I'm always, raising my arm, whatever, and my arm goes numb. Well, this is what you're going to do. You're going to you're going to ask, put an order in for an ultrasound, and you specifically want to say you want the ultrasound done with the arms up and the arms down. And so they just slap the ultrasound right here in the clavicle, look at that subclavian vein, and the ultrasound tech will be like, okay, sir, can you put your arm up? And they're going to take some images. Can you put your arm down? They're going to take some images. And you're going to see a noticeable lack of flow or a slowing down of flow when the arm is raised. We can also do this in MRI. We see this every once in a while. It's actually a fancy MR that we do, and we can diagnose Paget-Schroeder off of that as well. Whew. All right. Did that answer it? Making me go on tangents. Come on. Asking me what's TOS. But that's a good question, actually. Can you see pinch-off syndrome with a catheter in TOS? That's a good question. All right. Anybody else got any questions? Those last-minute little jabs at me right before I was about to leave. Okay, good. I got a smiley face from you. Thank you. You guys good? We're calling it April 2nd, live in the bag. I don't think I missed. I'm just scrolling through to figure out if I missed anybody else's stuff. The radiology guy, are you back to work right now? Hopefully you're not listening to me ramble anymore. You're out there making some money? All right, guys. We're calling it. I don't see any last minute questions. I'm about to press it. I'm about to press end. Later.